So, in our next session here, we're going to move into talking more about some of the actual issues with some of the new products that are out there for patients, including drugs. And in this session, entitled Unbundling with Purpose, Designing a More Patient Centered Payment System That Reflects Patient Priorities, we're going to be joined by Dr. Laura Williams, who serves as the Chief Patient Officer at Ardelex. Dr. Williams, I know you can talk about things that are very real world and examples that are coming from patients that you interact with regularly. As many folks know, on January 1st of this year, CMS implemented a major change by folding oral only medications, such as phosphate lowering therapies, into the bundled payment system. And while intended to streamline reimbursement, the move has instead exposed some very strong flaws in the overall bundle payment system. And we've been very focused on this in terms of the patient impacts. And we get our insights from patients and from clinicians in the field through our survey mechanisms. Earlier this year, AAKP conducted an independent survey through its Center for Patient Research and Education to find out how things were going. The results were rather troubling to us. Over 40% of dialysis patients indicated that they had experienced and disruptions in their access to oral phosphate lowering medications. And we're quite concerned about this. But the other thing that was interesting in our survey is 75% of the physicians who responded indicate that they were having problems and barriers to getting access to the right therapy at the right time for their patients. And Dr. Williams, I want to come over to you and have you walk through the implications of this policy shift, just in terms of people and what you see, because I know you have a heart for patients and you know firsthand you've never become detached from direct care. Go right ahead.
Yeah, thanks, Paul. I want to also echo my gratitude for being on the panel. I really appreciate it. And the statistics that you lay out here from the survey that you guys conducted, I think are really troubling. At the end of the day, what you like for any patient is to have shared decision making around the treatments and the care that they're receiving. And I think, Dr. Shaw just laid it out quite nicely. That shared decision making actually goes away in the setting where there is innovation, but not access. And so, from the standpoint of, particularly the phosphate lowering agents going into the bundle. Again, these are oral only therapies that are not actually related to renal dialysis itself. It's not part of a renal dialysis service. They should never even be there. But what it does, in a nutshell, is it just takes away innovation. I mean, we talked a lot about, sort of the innovation that happens from a preventive standpoint in this space, that we've had an explosion of that. And so when you look at, chronic kidney disease and just look at the last, 10 years, only 10 drugs have actually been approved in the kidney space. That's tenfold fewer than oncology. And most of those drugs, 60% of them, 6 out of 10 of them, were again, as Dr. Watnick said, in the pre-dialysis space. And I totally agree that preventive care is the right way to go. We want to look at ways to prevent people from getting to kidney failure. But as much as we do, there will still be patients who fall into that category. And what are we doing from an innovative process to make sure that we can make their lives better? I think phosphate lowering therapies is a potential opportunity to do so. When the kidneys fail, there's only two, sort of mechanisms to actually treat patients. It's either dialysis, maintenance dialysis, or it's transplant. And when we think about, phosphate lowering therapies, why is that important? Of all of the sort of, mineral abnormalities that happen once the kidneys fail, elevated phosphorus carries the greatest mortality or attributable risk to mortality. And so it's important, I think, for us to have every tool in our armamentarium to be able to manage that. And why is that important? Well, dialysis was never intended to be, a long-term solution. It was intended to be a bridge to transplant. And what we have seen, at least anecdotally, is that once we are able to actually control serum phosphorus, there are a number of patients who are actually become eligible for transplants, which is what you want. You're not only increasing survival rates by going through that path, but you're also decreasing cost to the system. So this, issue of putting these phosphate lowering therapies only magnifies the problem in terms of trying to actually get patients to where they need to be.
Thank you, Dr. Williams. One of the things that AAKP has focused on intensely in our congressional efforts and efforts before the executive branch, America is very committed to increasing opportunities for organ transplantation. But one of the issues that doesn't get talked about is transplant readiness, the ability of a patient to stay on the wait list or get waitlisted while managing other conditions. And I wanted to ask you a fast question here. On your experience in the patients that you work with, how big of an issue is this for transplant readiness for those people who are waiting for the opportunity to have a life-saving organ transplant?
Yeah, Paul, great question. I think it's a huge issue. And I think, while a normal serum phosphorus is not a formal criteria for a kidney transplant eligibility, that's often considered as part of a broader assessment for transplant readiness. Some people look at it from the standpoint of compliance and adherence, but quite frankly, we know that a lower serum phosphorus level at the time of transplant actually portends to a better graft survival rate. So transplant readiness and serum phosphorus are uniquely linked. And I think, again, having all of the tools in your toolbox to be able to manage serum phosphorus only gets patients closer to that goal. And certainly I have some anecdotal, sort of examples of that. But we need to actually look at data. We need to actually do research to show, again, that you know, controlling one's serum phosphorus is a way to get more people to the transplant list. And isn't that what we want? Isn't that, what we're striving for? Again, preventive care is the best. But once a patient actually gets to kidney failure, we also then want to give them the best option for success. And so we understand that there are limitations in terms of the number of organs available, but that shouldn't stop us from making sure that we get patients as close to possible in terms of transplant readiness. And I think managing serum phosphorus is one of those things that actually gets us there.
Thank you very much, Dr. Williams. I think you put a laser on the fact that a government determinant of health, a payment system that's outdated, can actually negatively impact transplant readiness and overall kidney health.